Gentlemen, this will be the first of several talks on medical ethics, which is a commonly tested topic on the USMLE, particularly Step 3, but it does show up on all steps. Medical ethics is a topic that's very near and dear to my heart. After I finished medical school, I did a master's degree in theology, particularly focusing on Catholic medical ethics, but we do have medical ethics in the secular tradition, which are pretty similar to what we have in the Catholic tradition. But this is very, very, very important for reasons I'm going to get into. If you haven't had the opportunity yet, please consider subscribing to my Patreon at www.patreon.com/pwbmd. If you could consider chipping in $1 a month, a little bit goes a very long way to help keep these videos free. If you subscribe, you'll have access to some of my premium content in which I go over case studies, formulating differential diagnosis and treatment plan, things that will come in useful for you as you take your steps as well as for clinical practice. Thank you very much in advance for your consideration. We're going to talk about 6 basic principles of medical ethics, which are commonly tested on the USMLE. These are very, very, very fundamental things that you need to have a grasp of, like I said, not only for the test, but for clinical practice. Because, unlike some of the really more complicated facts in medical practice, your cardiology and stuff like that. Yeah, it's important, but if you forget a thing or two, you can, you're allowed to make mistakes, right? This is something that you're not allowed to make mistakes in. You cannot violate medical ethics, and if you do, you can get into a lot of trouble. You misread a CBC or you misread a chest x-ray, you're allowed a certain amount of benefit of a doubt and allowed to make mistakes there. There can be consequences, but you're allowed to make mistakes. Medical ethics, absolutely not. You need to know this stuff, and it is tested on the USMLE, in my opinion, not extensively enough, because I have come into contact with plenty of providers who have really, really screwed up their medical ethics and really need some remedial training. So I really hope that you'll pay attention to this, like I said, not only for the test, but for clinical practice. So we're going to talk about why medical ethics are important and then go over some of these principles. I kind of put them in order of how important they are, but this is not set in stone by any means. So why are medical ethics important? Well, medical ethics will guide your decision making and your interaction and conduct with patients. It's a very important part of medical professionalism, which, is medical ethics, but it's also making sure you show up on time for your patients and making sure that you're dressed properly. And that's always, always, always expected. You are expected to know this stuff. And if you don't, you may get into problems with violations, and violations of medical ethics can threaten your job, it can threaten your medical license, and in extreme circumstances, it may even constitute a crime. Ethics provide us with a moral compass to use in situations that may not be very straightforward. However, on the test, I expect that you'll be given a relatively straightforward question when it comes to ethics. Most hospitals have ethics boards, which is usually for guiding clinical research situations, but certainly if you have a problematic ethical situation, you can always consult your institution. Very important caveat, what constitutes medical ethics can vary from country to country. Of course, I'm going to be focusing on the United States because my focus on all of my talks that I give are primarily for the USMLE. However, I think broadly within the Western world, medical ethics are pretty similar from country to country. Within the United States, it's important to be mindful of your institution, particularly if you're working for a religiously affiliated institution. Some of the ethical practices can vary pretty significantly, especially when it comes to end-of-life care, abortion, etc. So you want to keep that in mind as well. But for the test, we're talking about secular medical ethics. So the first concept I want to talk about is autonomy. And this is probably the most important one because it also tends to be the one that's most violated. Patient autonomy refers to the patient's right to make decisions for themselves according to their own system of morals and beliefs. So Patient education and informed consent are very important elements of proper autonomy. So if you don't educate your patient and you expect them to make a decision, they may make a decision that's not in their best interest. Whereas if you had educated them, they may have made a different decision. So part of respecting autonomy is making sure that your patient has all the tools necessary to make a decision that's in their best interest or that is within their value system. Now, that doesn't mean that their decision is always going to be the soundest one, but it does mean that you need to give them the tools that they need to make a decision that they feel is in their best interests. Confidentiality loosely fits under the umbrella of autonomy. I would say it also fits under the umbrella of non-maleficence, which we'll talk about in a little bit. When is autonomy challenged? This is very, very, very important because autonomy is not static. There are situations in which autonomy is not going to be recognized for very important reasons. So one is going to be incompetence, and the other is going to be incapacity. And these are two very different things. So you want to know the difference because the test may give you a choice between the two of these and expect you to know the difference. So in incompetence, this is a legal definition. An incompetent patient is someone who's legally deemed unable to make rational decisions for themselves. So most commonly, this would be a patient with advanced Alzheimer's dementia, for instance, would probably be the most common time we see this. So dementia. It's often due to permanent conditions. I suppose a person could be incompetent if their IQ is low enough, if they're mentally retarded, or what's the word we use now for that? Intellectually handicapped. These patients are assigned a surrogate by the court. So there will be someone that you can go to ask the questions that you would otherwise ask the patient. In any case, you need to tailor it towards the patient. So even though they may not be competent, that doesn't mean that they're not aware. And so you need to still respect their autonomy to whatever degree is possible. Incapacity is when the patient is clinically determined to be unable to make a rational decision for themselves. So this is not a legal determination. This is a determination that you make. And it can be due to transient conditions such as lack of consciousness, delirium, psychosis. If you have good reasons to deem the patient incapacitated, you certainly, it will often be respected by a court, but you need to, this is kind of a gray area, so you need to make sure that you're using good clinical judgment. In any case, if a patient is incapacitated, you want to check for a durable power of attorney. Do they have a contact on hand? Have they signed any paperwork that will give that decision making to somebody else? If they don't, or if there's no one available, then you certainly have the right to make the decision for the patient if they don't have a power of attorney. But if they do, then that decision making goes to that person that's on their power of attorney. And then if they're a threat to themselves or others, usually this is going to be in psychiatric settings. Certainly a patient will lose their autonomy if they're threatening to kill themselves. They have a concrete plan for suicide. In that case, they don't have the autonomy to go out and go home. They will be involuntarily admitted. A very important concept, too, is paternalism. And this used to be kind of a practice that we used to do a long time ago, back in the 1970s, 60s, and before we really started thinking about patient-centered care. And paternalism is the practice of making decisions for the patient without seeking their input. So what paternalism isn't, and there's often some confusion here, paternalism is not refusing unnecessary care for the patient. So if the patient requests something, that doesn't mean they're always going to get it. I worked with a doctor once who said, the hospital's not Burger King, you don't get to have it your way. And that might be a real crude way of putting it, but paternalism does not mean you can't put your foot down and say, no, this is not in your best interest, I'm not going to do this for you. A good example of that would be something like opioids. So I'm not going to provide you opioids because I don't think it's in your best interest. That is not paternalism. Paternalism would be doing a surgery on a patient without their consent because you think it's in their best interest. That would constitute assault. So that would be a gross violation of autonomy. That would be paternalism in the extreme. But really, making sure that you are not paternalistic, the best way to get around that is to make sure that you are getting informed consent for everything you do. Beneficence is a value in which the provider takes actions or recommends courses that are in the patient's best interest. Beneficence is simply being your patient's advocate, doing things for the patient that you would want done for yourself or done for people that you love. It's about acting in the patient's best interest. Now, that doesn't mean that it's doing something in the patient's best interest, even if it's objectively in their best interest, without the patient's consent. So note that I highlight here, it is not coercing or manipulating the patient into making a decision that's against their values, even though it may objectively be the best decision for their health. You still need to provide informed consent. You still need to give the patient a choice. In most states, beneficence does not constitute euthanasia. So a patient may request euthanasia, but if it's not legal, then that does not fall under the category of beneficence. Please keep the individual patient in mind. Beneficence is not the same in all situations. So if the patient, for instance, is a Jehovah's Witness, beneficence is not giving them a blood transfusion, even though it may save their life. That, again, falls under autonomy. Autonomy tends to trump all of these other values. When patients' autonomy is compromised, beneficence needs to be the guiding ethic. So if it comes down to that the patient is incapacitated, there's nobody else to make decisions for the patient, then you become the decision maker. And in that case, beneficence is going to be your guiding ethic. Non-maleficence is different from beneficence. So non-maleficence is about what you don't do, whereas beneficence is about what you do. So non-maleficence is closely related to beneficence, but it has to do more with what you don't do. So don't do harm. You know this maxim in medicine, primum non nocere, which means first do no harm. And that is commonly attributed to Hippocrates, but I'm not sure if he actually said that or not. So it's abstaining from any action that may bring harm to the patient. Beneficence is what you do, maleficence is what you don't do. So it would be something like I alluded to earlier, refusing to prescribe opioids when deemed not necessary. Non-maleficence and beneficence can conflict. In this case, patient or proxy input can help. A very important part of non-maleficence is the principle of double effect. And I believe this was originally, it may go back to some of the ancient philosophers, but it was really St. Thomas Aquinas that really elaborated on this, and this has made its way into secular thought. So the principle of double effect means that unintended medical consequences, even if they're bad, are acceptable if the intended consequences are legitimate and the harm is proportionately smaller than the benefit. So it's okay to do something that may have negative consequences as long as the positive effects outweigh those negative consequences. So a straightforward example would be removing an organ or a limb that's causing disease. So it's what normally would be not okay to just go in and remove a patient's spleen or remove their appendix without their consent. However, if that organ is diseased, then it's certainly okay to remove that even without their consent. So if you were going in and doing a surgery for one reason and you noticed their spleen was bleeding, well, you certainly can remove that spleen. So even though there's the consequences of, you're removing something without the patient's consent, you're removing an organ, the benefit to them not dying, for instance, or not suffering the negative consequences of that would outweigh the negatives. So that's the principle of double effect. Another example, a little bit less straightforward, would be providing high-dose analgesics to a hospice patient. Even though you may not prescribe that level of analgesics to the average patient, you can provide it to the hospice patient to comfort them, even though it may unintentionally shorten their life. So the negative consequences outweigh or are outweighed by the benefits of providing them comfort. And then one thing that's controversial, depending on the setting that you're practicing in or your own values, would be performing an unrequested abortion to save the mother's life. In general, I would say for secular practice, you would do that. If the mother is not able to provide consent one way or another, if she's incapacitated for whatever reason, then you need to act to save the mother's life, even though you're performing an abortion. But all of these have caveats. If the patient tells you, and they're competent and they have capacity, and they tell you they don't want you to do something, then autonomy will trump this. So very, very important. Veracity or truth telling. This is simply honesty. This really comes down to just being a moral person, really. The most important part of veracity or truth-telling is revealing all the pertinent details of a patient's medical condition to them, as well as the risks and benefits of a procedure and their prognosis if it's known. So this comes down to informed consent. It also includes informing a patient of any mistakes that have been made in during their care. So if you nicked a vessel during surgery, even if you repaired it, you need to inform them of that. This is part of being honest with your patients. So, like I said, a critical element of ensuring informed consent. Veracity is not telling a patient information that they tell you they don't want to hear. So in certain cultures, I think in South America, Central America, they don't want to know. A lot of times they don't want to know certain aspects of their prognosis. So if they tell you they don't want to hear something, then you don't tell them. So it is okay to first ask a patient if they want to hear their prognosis. And it's also okay to delay telling a patient their diagnosis until they're ready to hear it, although it should never be delayed if it may compromise their ability to provide informed consent. So it's okay to ask to tell a patient, hey, I think you may want to have someone else here. This might be difficult for you. You can do that, but if they tell you, no, I want to hear, then you need to tell them. When's veracity challenged? Veracity can be challenged if a patient may be reasonably expected to engage in self-harm with the disclosure. So if this is a patient with a history of suicide attempt, very, very depressed, you may wait to disclose it until they have somebody there with them. Certainly if they want you to tell them right now, then you need to be ready to you need to be ready to admit them involuntarily if they give you any inclination whatsoever that they may harm themselves. So really using your clinical judgment. All of these caveats aside, it is never okay to lie to or deceive a patient for any reason whatsoever. So that you need to know. Even though you may withhold the truth temporarily, that may be okay. It's never okay to tell a lie or to deceive the patient. Distributive justice. So now we're getting more towards vague concepts. So distributive justice is the proper allocation of resources in a manner that's fair and just, but not necessarily equal. So it's not necessarily equal allocation of resources. And we see this pretty often. We see this with triage. So triage is a common example of distributive justice. The first person through the doors of the ER is not necessarily the patient that's attended to first. Certainly if you have a person that comes in sitting in the waiting room with an ankle sprain and they're up next to be brought back into the ER, if somebody comes in suffering from symptoms consistent with an acute MI, for instance, that patient's going to obviously be seen first. Other instances, you may spend more time with a very ill patient than you do with less ill patients. That's okay. It's even encouraged because very ill patients need more care. In nursing, nurses often have to choose which patients to respond to first when several call lights are on. Definitely the sicker patients will have higher priority. A more contentious issue in distributive justice here in the US is universal health care. People disagree on whether healthcare is a right. Personally, I feel it is, but that's a disagreement when it comes to distributive justice with healthcare. When's distributive justice challenged? When you have VIP patients. Now, really, this should be a no-brainer. All patients should be treated the same. However, you can run into problems. You're dealing with the governor or a senator or something like that. It may be tempting to provide that patient with a higher level of care because they're more powerful. But as part of medical ethics, all patients are treated the same. So you're not going to treat a patient who is an important person or has more power with any differently than you would treat that person if they weren't to have that power. And then finally, proportionality. This is a principle that ensures medical treatment or plans that are commensurate with the illness or with the goals of treatment. Really, what this comes down to, even though it's kind of vague, is ensuring that the benefits outweigh the risks. So, making sure that you maximize the benefits, which is beneficence, and minimizing the risks, which is non-maleficence. Often, this plays a role when an ethic may be legitimately compromised or when two or more ethics conflict. So, as a summary, ethics are the cornerstone to the proper and professional practice of medicine, although what's ethical in one situation may not translate exactly to another. So, clinical judgment does come into play. Autonomy is the patient's right to make decisions for themselves. Paternalism is the opposite of autonomy in many senses. It's making a decision for the patient without their input. Beneficence is doing or recommending actions that are in the patient's best interest. It's what you do. Non-maleficence is refraining from actions that are harmful to the patient. It's what you don't do. Veracity or truth-telling is revealing all information to a patient, all critical information to a patient, especially when requested. Distributive justice is allocation of resources in a manner that's fair and just, although not necessarily equal. And proportionality is ensuring that the benefits outweigh the risks. All of these ethics, they can come into conflict with one another. For test-taking purposes, my advice to you is that autonomy usually trumps when there's conflict, but autonomy can be compromised in certain situations if the patient is incompetent or incapacitated. And that's all I've got for you with the basics of medical ethics, and I will see you next time.